differences between treating male and female patients is just to not pathologize relational styles for women patients, that the codependency, or labeling something codependent, or saying that somebody is not becoming autonomous and self-reliant is important. That has to be tempered with, there's a school of thought saying that developing, balancing self-nurturance and care of others is the developmental task for a woman patient versus a man patient, not separation and individuation or autonomy. These are more male concepts, probably developed by male psychologists with male college patients. And it doesn't have some of the relevancy that used to be seen that they have. Research shows that women prefer less hierarchical and more collaborative relationships with therapists. Different styles relating may be in order. And if that's difficult for a therapist, then that's something that needs to be considered clinically. High incidence of PTSD. Okay, pharmacological treatment of addictions. Naltrexone is the most studied. Naltrexone is a opiate antagonist, and it seems to reduce things like drinking days, and it does seem to have some effect on cravings and urges. And this may be important for really pathologically patients with a lot of diagnoses who've been in multiple treatments and things aren't working. That's where I think the pharmacological approaches start to become something that should be seriously considered. We'll probably see that more and more in the future. Nalmefene is another, or Revex is its trade name, is another opiate antagonist. It seems to be doing a little better than naltrexone. I don't know if it's available in this country yet. For the last research, Dr. Chief's shaking his head. It's the research I showed up in 2000, not available here yet. But hey, if it's available in Canada, you can still get it. Acamprosate is another opiate antagonist that doesn't, when I looked at the research on naltrexone and that, doesn't seem to be doing as well. It's not available either, right? Coming soon to a drugstore near you, though, probably. Yeah. SSRIs are been studied. Things like Prozac, and for some patients, especially depressed and anxious patients, help with reducing drinking days. Ondansetron, which is a serotonin antagonist, so apparently serotonin is involved in mediating dopamine release in the addictive pattern. It seems to help with this early onset type 1 alcoholics, the ones with more psychiatric disturbance, earlier onset of severe drinking problems, and it doesn't seem to help with type 2, later onset, more monosymptomatic patients. Lithium doesn't seem to help very much. Now, in some programs, you go on these medicines automatically. It's a reflexive move. You go to a place and you're put on it. I know programs, if you're alcoholic, you get on an SSRI. Because of the incidence of depression, because of some of the studies showing that it has anti-addictive effects. So it's like, to some doctors, it's kind of a no-brainer. Hey, it's a big problem. Why not, throw everything at the kitchen sink at this disease? And I think that there's, that's a viable treatment philosophy. It isn't the one that we espouse, but in some places it is. Okay. Now coming to the last comment I want to make is on the importance of spirituality in treatment. There's a lot of research going on now on the cumulative and eventually permanent effects that spiritual practices have on central nervous system or autonomic nervous system. And we now know there's 3 different universities are doing a lot of this research. And we now know that engaging in deep meditation and prayer has some very powerful anti-addictive. And I think it's interesting to me because we really haven't gotten into the anti-addictive effects of studying spirituality so much yet, but it's starting to come up. I just read a recent paper by Dr. Andrew Newberg at the University of Pennsylvania, and he showed that when somebody meditates, the following neurochemicals are changed appreciably. Vasopressin, gamma-aminobutyric acid, which is involved with reducing anxiety. Melatonin is increased, serotonin is increased, and norepinephrine and cortisol are both decreased during, and appreciable, measurable decreases during spiritual practices. Eventually, spiritual practices reconfigure neurophysiological, neuropsychological functioning until what we call serenity can become a permanent state. For serenity and well-being to be available to somebody on a regular basis, they have to have an underlying neurophysiological support. And this is the direction this research is going in. There was a recent study showing, measuring what we call EEG coherence. Advanced studies of the electroencephalogram on patients who have been meditating for a long time have shown that the meditative response that is experienced during meditation breaks through just meditation and is experienced 24 hours a day during activity, even during doing demanding cognitive tasks. So this idea of enlightenment, this idea of this inner light goes on, or this inner serenity, is not just fanciful thinking, or it's not just something that you have to be a monk to do, or a nun, even though they're studying monks and nuns. It's something that anyone can access. And that we now, in addition to the fight or flight response and the relaxation response, we have the spiritual response. That the brain functions in a certain way, in a certain sequence, when the spiritual response is accessed and activated by spiritual practices. So you can look at spiritual practices as technologies that change how the brain functions. I think the research is going to show, and that really the founders of AA intuited, that it's no surprise that spirituality and spiritual practices are one of the best antidotes to addiction. That there's a neurophysiological reality to it now. And the last part of this talk, I talked about the spiritual awakening, some of the studies that are going on. I was involved in some back in the early 1990s on the practice of effects of transcendental meditation on addiction. So when someone's in a spiritual mode of being, it's not just something that has to be restricted to prayer and meditation times. In fact, the whole goal is to, if there's a goal in spirituality, if you think of it in those terms, it's not really usually thought of in those terms, it's to permatize that, to always be in God consciousness, always never feeling separate from one's higher power. And, for even the Judeo-Christian tradition, in the Bible, Christ was speaking to his disciples one time, and he said, I am the vine and you are the branches. I don't know if you remember that particular quote, where he was describing the relationship of him to the rest of humanity and the overall creation. That there is no the vine and the branches it's all one part of one plant. This idea of being separate and disconnected and fragmented and alone, this is all delusional. But it can be someone's reality if they're depressed and they're shooting heroin and they have no family support, and one can feel as if they are adrift. But just like the vine and the branches, the separation is apparent rather than real. And I think that spiritual practices are very important for this population because they have, lots of times these patients get sober and they're not happy. They don't have a lot of the automatic kinds of benefits that come when somebody gets sober because they have mental illness to deal with. And that's why, to me, they more so need to offset hopelessness and helplessness with activating the spiritual response. We should be meditating, praying, engaging in spiritual activities, 12-step work, spiritual retreats on a regular basis. I think that is,